In this mini-series, we'll be discussing incontinence. The definition of incontinence is an involuntary loss of urine. There are a few different types of incontinence. So stress incontinence is the inability to retain urine when laughing, coughing, sneezing, etc. And this is really an issue with the intra-abdominal pressure and its effect on the urethral sphincter. Urgency incontinence is the involuntary loss of urine with sudden and extreme need to void. You can also have mixed incontinence, which is a mix between the stress and urgency incontinence. There's overflow incontinence, which is bladder outlet obstruction, detrusor underactivity, and chronic urinary retention. And then overactive bladder is urinary urgency, frequency, or nocturia, and this can be with or without incontinence. So this is a slide that's in the American College of Physician recommendations on treating incontinence in women. And it's essentially just some non-pharmacologic treatments for urinary incontinence that you may want to try with your patients before going to drug therapy. Next, we'll hit on a few of the major classes that are used to treat urinary incontinence. The first is topical vaginal estrogen, and this is indicated in women who have stress or urgency incontinence that's associated with menopause. The way that this works is that it essentially helps with vaginal atrophy that happens during menopause, which tends to cause the urinary incontinence symptoms. There are a couple different formulations of the topical vaginal estrogen. There's a cream, the brand name is Estrace, and this comes in, the dose is 0.5 grams intravaginally twice weekly, and there's an applicator that helps the patient to measure out exactly what they need for a dose. Vagifem are the intravaginal tablets, and that's 1 10 microgram tablet twice weekly. And then lastly, there's a vaginal ring called the S-string, and you insert 1 2 milligram ring intravaginally, and that's replaced every 90 days. These medications can take a while to start working, up to 3 months for the patient to see some benefit from it. Overall, though, it's very low systemic absorption of estrogen. So some of the side effects that we think of when we think of patients taking estrogen, we think of cardiovascular disease, increased risk of breast and endometrial cancer, or possible dementia. But really, the risk with these agents is much lower because it's not systemically absorbed much. Antimuscarinic agents are probably the largest class used to treat different types of urinary incontinence and overactive bladder, so we'll spend the most time on these agents. The way that they work are that they stop the binding of acetylcholine to the muscarinic receptors in the bladder. Normally, when acetylcholine binds these muscarinic receptors in the bladder, it causes contraction of smooth muscle and therefore urination. But by blocking these receptors, it helps to relax these muscles and therefore decreases urinary incontinence or overactive bladder symptoms in patients who have too much contraction at baseline. So, like I said, this is the most common medication class. They tend to have tolerability issues, especially in older adults, and we'll touch on some of the adverse drug effects that can happen with these. If a patient is started on one of these agents and it doesn't work for them, it is reasonable to try a different antimuscarinic agent because there is a potential that that one could work for them. So just because they fail one antimuscarinic doesn't mean that they would necessarily fail another. Contraindications that exist to all antimuscarinic agents are myasthenia gravis, gastric retention, and narrow angle closure glaucoma. Antimuscarinic agents are a subset of anticholinergic medications. The side effects that we think about have to do with turning off the parasympathetic nervous system. So when we think of the parasympathetic nervous system, we think of rest and digest. And when we turn that off, we think of having the opposite problems. So side effects that you tend to see with all antimuscarinic agents are dry mouth, constipation, blurred vision, tachycardia, drowsiness, dizziness, and decreased cognitive function. Each of the individual agents will have some varying percentages and likelihoods of causing these adverse effects, which we'll discuss in a few minutes. Antimuscarinic agents have drug interactions with several different medication classes. The common theme with all of these medication classes is that they have anticholinergic properties to them. So commonly we would think of antihistamines like Benadryl, because those are your classic anticholinergic medications. Other classes that have these effects are muscle relaxants, TCAs, antipsychotics, um, and then we also worry about CYP enzyme inhibitors like ketoconazole and clarithromycin because those can increase the effects of antimuscarinic drugs. This slide is just an overview on some of the most common antimuscarinic agents. There are a few things that I just want to highlight about each of the agents. You'll see that each of them a lot of them have several different formulations between immediate release and extended release tablets. So that'll be something that's really important to keep in mind when you're prescribing these agents, is that you're prescribing the correct dose and frequency and choosing the correct formulation that goes along with that. So oxybutynin to start has several different formulations. The most common ones are the immediate release, extended release, and then the patch. The patches are actually over the counter in the US, but access to them can be limited. We tend to not use the immediate release of oxybutynin because it's harder for patients to remember to take it several times a day, and side effects can be worse. But this could be beneficial if patients have incontinence that's worse at a certain time and they just want to take it at that certain time. This medication is often not tolerated in older adults because it has many and pronounced anticholinergic side effects. Tolterodine specifically can cause QTC prolongation. Um, Darafenicin and trospium, one thing I want to touch on with these medications is that theoretically they don't cross the blood-brain barrier. So they were intended this way so that they wouldn't have as many CNS side effects, so the dizziness, drowsiness, cognitive dysfunctions. But there are still safety concerns with these medications just because we haven't had the trials to really look and see if they're better at preventing these side effects. Another good agent for patients with urinary incontinence or overactive bladder is mirabegron or mirbetriq, and this is a beta 3 adrenal receptor agonist. This medication works by relaxing the detrusor smooth muscle and increases bladder capacity. Um, the beta 3 adrenergic receptor is also quite specific to the detrusor muscle. So, this medication has fewer adverse effects than you'll see with the antimuscarinic agents. The dose is 25 milligrams daily, and you can increase the dose to 50 milligrams daily if needed in 2 to 4 weeks. It is renally dose adjusted. You can use this medication with or without an antimuscarinic agent. You would think about doing this if the patient can't, you think about using it without an antimuscarinic agent if the patient can't tolerate an antimuscarinic, for example, a patient with dementia. Or you could add it on top of a lower dose antimuscarinic agent for a patient who gets some benefit with an antimuscarinic agent but can't tolerate a dose increase. These agents are contraindicated in patients with uncontrolled hypertension because there is some concern with increased blood pressure with this agent. Adverse effects include hypertension, like I just said, headache, tachycardia, urinary retention, and there is less dry mouth and constipation than with the antimuscarinic agents. Lastly, a medication that's shown some benefit in incontinence is duloxetine. Really, this is used in patients with depression who would have concomitant incontinence, and this is a way to get away or try to get away with using one medication as opposed to multiple. So, as we know, this is a serotonin norepinephrine reuptake inhibitor, and for details on that, I'll refer you to the depression medication lecture.